Good afternoon, everyone. Thanks so much for joining. Looks like we have still some folks trickling in, but we'll go ahead and start off today. My name is Mary Ellen Mathis with Health Management Associates, and welcome to this afternoon's CalAIM webinar series, Special Populations Within the Justice System. As for today's agenda, we will go ahead and begin with some welcome and introductions, go over our learning objectives, introduction to LGBTQIA+ populations, including the justice system, introduction to pregnant populations, and the justice system. We'll go over a few scenarios and a Q&A at the end. As far as a little bit of housekeeping today, as an FYI, this webinar is being recorded and attendance will be tracked via login. If you have any questions or concerns or have any IT issues, send a message to the host if you cannot hear or see the slides. And then as an FYI, after the webinar, you will get a copy of the PowerPoint and the recording link. Just a heads up, all participants are automatically muted. And if you have any questions or concerns, please feel free to communicate via the chat. If we aren't able to get to any of your questions today during our webinar, we will be happy to address them afterwards in an upcoming forum. Next, I'd like to kick it off to Nye for a few introductions.
Great, thank you so much, Mary Ellen. Good afternoon, everyone. My name is Nye Kasich. I'm Vice President Medi-Cal Lead at HealthNet. Thank you so much for joining us on the Justice Involved webinar. This is the third session in a series of 4, and HealthNet is happy to partner with today's speakers, Carol Clancy and Rachel Johnson-Yates. They are experts in Justice Involved system, and Carol and Rachel will help us understand the needs of Justice Involved population today. HealthNet recognizes the important role that you play, and we thank you for helping us implement this very important program across the state of California. We welcome your feedback and encourage your active participation in today's webinar. I will turn it over to our speakers.
Thank you, Nye. As we get started, if you would, in the chat, please let us know what county or counties that you serve. We'd like to use this information to help tailor some of the content today and to be able to be more responsive in future trainings and presentations that we are creating. So I see a lot of people already typing in the counties that they serve. Seen some Imperial, Los Angeles. Let's see. Ooh, coming in fast. LA.
Keene, Tulare.
Thank you. Fresno. All right, this is great. San Diego and Riverside. Got some people with some big county reach here. This is great. All right, keep the counties coming in, please, because we do track this. So thank you for taking a moment to put that in the chat. And if you don't mind going to the next slide, we will talk a little about our learning objectives. So at the end of this webinar, we want you to be able to talk about the epidemiology of special populations in the criminal justice system. And today we'll be talking specifically about people who are justice involved as well as part of the LGBTQIA population and people with SUD. We will also be summarizing key evidence-based practices in working with and in the management of individuals who are pregnant and postpartum that have OUD, and as well as the care of their newborns. So another just kind of pulse check activity real quick as you all are finishing up putting in your counties in the chat. If you wouldn't mind, there's a poll getting ready to launch on your screen. Could you please indicate whether you are an ECM provider? And if you are an ECM provider, let us know if you serve those who are justice involved. Okay, so responses are coming in quickly. We're seeing the vast majority right now, hovering around 90% of folks are ECM providers. We're hitting about a 50-50 split at this point about whether or not you're serving justice involved folks. Looks like we've got about 43 of the 107 participants that have responded to the poll so far. So if you don't mind taking a second, should be popped up on your screen. The responses are still coming in. We're hovering about 82% yes, ECM provider. Right around 44% are serving folks that are justice involved. 55% not at this point. All right, wonderful. All right, next slide, please. So part of the reason why we are doing this series is because there is often a lot of stigma that is associated with who we call special populations in the work that we do. So all people that are involved in the justice system are subject to stigma and judgment by healthcare providers. We know a lot of the times individuals' rap sheets come before who they are as a person, as an individual. A lot of times we, as healthcare providers, can fail to consider the trauma, the life circumstances, the complicating factors that may go into the development of a person's substance use disorder, the development of a person's mental health issues, the combination of the two that have led often to their justice involvement. So today we're hoping to learn more about special populations, what puts them at risk for incarceration, what increases stigma that they experience, and how this is important for ECM providers to understand. What we know is that the more that we know and understand and learn about stigmatized populations, the less likely we are to engage in stigmatizing behavior ourselves. And as we mentioned, today we'll be talking about two special populations, what places them at risk for incarceration, their types of stigma that they endure, and how we can do better in supporting them. Next slide, please. So as we're talking about this first population, which is the LGBTQIA population that is involved in the justice system, I think it's really important to kind of make a couple of considerations as we go into this topic. First and foremost, I am coming to this conversation as both a behavioral health professional, an individual that has spent most of my career working with folks who are justice involved in prisons and jails, in reentry facilities, probation, parole at a federal, state, and county level. I'm also coming to this training with lived experience as a proud member of the LGBT community. My wife and I and our 6-year-old daughter live in Indianapolis, and really come to the table with a lot of lived experience, as well as experience facilitating trainings and education in equity and education spaces to help people better understand the needs, the terminology, the lived experience of these populations. And so what I would like to request is that people do their best to understand, first and foremost, why we are here. So we are here to be able to better serve and understand the individuals that we work with. Bring to the table language that you have. One common mistake that people make is being so afraid of using the wrong terminology that they don't ask a question that would help them improve their practice or improve their engagement with the people around them. This is a learning opportunity. If you have a question you want to ask and you don't use the correct terminology, we might gently replace the language that you use, but in a manner that is respectful of you trying your best to learn more. And first and foremost, that is what's most important, is that we're all here to learn, and as we learn, we do better. And that's one of the main goals of us being here today. And lastly, if any of the conversations, topics, points spark some curiosity in you, we definitely encourage you to take it upon yourselves to learn more about the lived experiences of individuals in the populations that we are describing. This is very, very important, as a lot of times we will think we understand, make assumptions about various groups of people. And what we find is, as we get to know individuals more, and as we get to know about how individual stories make up experiences that groups tend to have, and how there's differentiation in between every story in between, we start to develop a lot more empathy, a lot more understanding, a lot more patience. And as a result, our practice improves dramatically. And so I would like to just kind of kick off this presentation with those invitations. And so as we start talking about and I will be using the term LGBT just for the sake of linguistically being able to not stumble over my words. The acronym that is used most commonly right now is LGBTQIA, and I'll be going over, and with a plus sign at the end, and I will be going over what all that stands for here in a few minutes. But as we start to talk about this topic, it is really important that we kind of get some operational definitions together here, and so that we understand where all of this is starting, and when I use certain terms, that we all have kind of a baseline understanding of what it is that I'm talking about. It's really important that we understand that sex is a complicated combination of many, many different variables, and that there's a significant variance among each individual. So sex is the term that we use to refer to how we are typically assigned at birth or during an ultrasound based on the appearance of our external physical genitalia. And there is kind of a remarkably common occurrence of external genitalia having an ambiguity and or other indicators that may be internal sex characteristics, chromosomal differences, hormonal differences that will be considered to assign a sex. I, many years ago, was teaching a human sexuality class here in Indiana, and that's when I first started understanding the actual prevalence of some of these factors, much more than I had much of a conceptualization before. And it really changed my understanding of the world around me and the lives that people were living and the things that people may feel like they have to keep a secret that could potentially feel very scary due to lack of understanding. So about 1.7% of our population are born with some level of intersex traits. And so what's really important is that we understand that means, again, there can be hundreds of variations, both with physical characteristics, chromosomes, and hormones that affect differences in presentation that we would categorize as being intersex. And just to give a frame of reference, because when you read 1.7%, you think, well, that's not very many people, but it's actually 5.6 million Americans are believed to be born with intersex traits. And when you think about that, there's only a 0.3% chance of having identical twins. And most of us probably know a couple of families that have identical twins. Compare that to the rate of individuals that are born with some sort of intersex trait. About 0.5% have genital differences that result in often an unnecessary surgery. And so this is a really important factor to know, is that a lot of times at the time of birth, if there are any sort of genital variations that make physical sex difficult to cleanly determine based on the standards that we have today, oftentimes a surgery will be the answer, when often the surgery is in fact cosmetic and not necessary for the individual's functioning and health. Next slide, please. So then we talk about gender. Gender identity and expression is our internal perception of how we identify or express oneself. This may or may be in line with some of the societal definitions of how it does or does not match with our sex characteristics that were mentioned before. So the term cisgender, and many of you have probably heard some of these terms, but cisgender is a term to align a person whose gender identity aligns with the sex assigned to them at birth. So a cisgender person is somebody that is born with typically assigned male or female genitalia, and they will identify categorically that in a way that is aligned with the genital identification and assignment. A person that is transgender is an individual whose current gender identity and or expression differs from the sex that they were assigned at birth. They may have transitioned or be in the process of transitioning in terms of how they are living. There are many people who identify as transgender who are not transgender openly, that may present as one gender publicly most often for their safety, when internally they know that they are in a body that does not align with their gender identity. There's another term that is called gender expansive, and this refers to an individual who expresses their identity along the gender spectrum. So this may be a person that feels really connected to multiple gender identities or no gender identity at all. And so some terms that you may hear around someone who is gender expansive are terms like genderqueer, gender nonconforming, non-binary, agender, two-spirit, etc. What we know to be true is that individuals that are transgender or gender expansive have existed and been documented since the beginning of time. For the sake of time in this training, I didn't have the opportunity to do a whole diatribe into the history of transgender and gender expansive folks, but it is a really fascinating, understated, and often undercommunicated history. In the indigenous population, as an example, There's a lot of documentation that those who identify as Two-Spirit were actually honored in their community. And there's many other examples in many other cultures of this being a similar and true experience historically. If anyone has any questions about any of these terms or other terms that you have heard, please throw it in the chat. I'm very happy to answer any of these questions. So then the next slide talks about sexual orientation. So sexual orientation is usually a combination of a person's sexual and romantic attraction. And there's a lot of other variables in there that can be considered as well. But kind of the most basic description of sexual orientation is that we're talking about what it is that I am sexually, often physically attracted to, and what it is that I am romantically attracted to as well. So sexual attraction is having heightened interest in somebody because they stimulate sexual desire or arousal. Romantic attraction is having heightened interest in someone because they stimulate emotional or romantic desire. And oftentimes sexual and romantic attraction do align, but sometimes they don't. And that is also important to understand as people are describing or determining or exploring what their identity might be. Next slide, please. Intersectionality is really incredibly important and really is at the core of a lot of what it is that we'll be talking about today. So it is crucial that we understand this term intersectionality in terms of understanding that all aspects of our being intersect in a manner that has an impact on the level in which we might experience marginalization. The qualities can both be empowering and causes for experiences of oppression. And so what's really important to understand is we have some characteristics that are more prevalent in our society and then tend to be viewed as the norm due to their prevalence. And so the further away that you get from what is seen as the most common, the more likely you are to experience instances of discrimination, hardship, et cetera, trauma related to who you were born as a person. And so what we know is if you are different than the norm in terms of your race, your ability, your age, your sexual orientation, your gender identity, your class, your weight, physical appearance, I mean, any number of things, each one of those areas in which you differ from the norm is an increase in likelihood of discrimination, trauma, et cetera, that you may experience. So as you're working with your clients, a lot of times, if we are folks that consider ourselves to be allies or supporters of individuals that are marginalized or individuals that really have a passion for promoting and developing equity and equality in the spaces that we occupy, we have to be really cognizant to make sure that we haven't inadvertently developed blind spots in these areas. As an example, in my own life, I have had friends that just absolutely did not have on their radar that it was even possible that maybe I would have experienced some sort of discrimination based on my sexual orientation. Because from their perspective, it was a non-issue. And so it's really important that we understand when we're talking with our clients and we're asking questions and that we're having conversations that say, when they bring up their sexual orientation or their gender identity or their race or their ability, that we ask questions that are intentional and saying, how has that impacted your life? Where has that made things easier? What parts of that do you feel really, really proud about? And in what ways has this made your life harder? And that we understand that though there are often trends in each of these different categories, that each individual's experiences are unique, and the combination of these experiences really lead to a rich tapestry of often complicated experiences with others, and especially with power structures. And as we talk about incarceration, all of these factors are incredibly relevant. Next slide, please. So there are often a lot of sometimes changing acronyms within the LGBTQIA population. But generally speaking, this is the way that we define LGBTQIA. And there are other identities that exist outside of this kind of standard acronym that are equally as relevant and valid. but this tends to capture most of the identities that fall under the LGBTQIA umbrella. So L is for lesbian, and that's usually a female identified person that is attracted to females. Gay often refers to men who are sexually, romantically, and or romantically attracted to other men. Can also be used interchangeably with lesbian. Bisexual is somebody that is attracted to the definition. It kind of can vary depending on who it is that you're talking to. Bisexual can be both genders or anywhere along the gender spectrum. There's also pansexual, which is a person that identifies as being attracted to any gender. As we mentioned, there is transgender, which is an individual whose gender identity does not necessarily match their identity given at birth. Queer or questioning. Typically, just as a point of reference, the term queer is usually has kind of been reclaimed by the queer community. If you are a person that does not identify as being LGBTQIA or queer, I would shy away from using the word queer yourself, unless the person you're working with or the person you know has used that and given you permission to use the word queer, because that is how they identify. So just kind of be thoughtful around your use of the word queer. Can also mean questioning. We've discussed intersex and what that means. And then there is also the asexual population. So this is a group of folks that have varying levels of sexual desire or sexual interest along a continuum, all the way to not having the experience of often or ever having sexual desire or attraction. And then the plus kind of includes everyone else that has an identity outside of the heterosexual and cisgender identity. So if there's any questions about any of those acronyms, please feel free to jump in with those. Next slide, please. So considerations as we're talking about these groups. So people with complex needs have many also complex stressors that they're juggling that affect behavior and stress management. And as we're talking about both of the populations that we're discussing today, it is really, really critical that we operate from a perspective that we are assuming trauma. And this cannot be overstated, actually. So what we know is that 95% of those seeking treatment for SUD report a trauma history. 90% of people at SMI report a trauma history. Similar rates of those who are justice involved report a trauma history, and similar rates experience trauma while they are incarcerated. And so this is really important to make sure to keep front of mind. We have whole other trainings that could last for weeks about trauma-informed care and what it means to assume trauma. But what we know is if we can start from a baseline of assuming that the person in front of us that may be having behaviors that are confusing or concerning, that those behaviors are a product of the trauma that they have experienced, that helps us increase our understanding and make us more effective in the way that we're approaching the issue. Next slide, please. So now it's kind of time to talk about the intersection of the LGBTQIA population and overrepresentation in the justice system. So first, we're going to talk about what, and then we're going to talk about why. What we know to be true is that lesbian, gay, and bisexual people are incarcerated at a rate of nearly 3 times that of straight people. And we know that LGBTQ youth are overrepresented in the juvenile justice system at a rate of almost double the straight youth. And so what you see is that early in an individual's life, they will be overrepresented in the criminal justice system, and that disparity starts to increase exponentially as the life span goes on. Next slide, please. So why the disproportionate representation? And the why is really, really, really important to understand. What we know is that nearly a quarter of LGBTQ plus people live in poverty, and that number increases to 31%. So nearly a third of LGBT people who are also Black or African American are living in poverty, as compared to 6% of the cisgender straight population. Reasons why that occurs. So what we know to be true is that when individuals come out or are found to be part of the LGBTQ plus population, that instances of family rejection, often in the early teenage years, occur. So often we see that youth will be kicked out of their homes, that they will be forced to live on the street or in unsafe environments, which increases their likelihood of being involved in the justice system. We see a lot of employment discrimination for people whose sexual orientation is different than heterosexual. If they have physical presentation that does not match the societal norm, a lot of times that can make it more difficult to get or maintain employment. We know for our transgender friends that especially if they do not, quote, pass, which means that their gender identity matches their physical appearance as perceived by others, that often it is very, very difficult for them to be able to secure employment. We know that gender affirming healthcare often has a high cost to it, that coverage for gender affirming care varies state to state. We know that shelters are very difficult for people to find, and shelters that offer safety for the LGBTQ population. We know that often treatment providers don't understand how to effectively work with the LGBTQ plus population. And so we still have treatment providers that are not gender affirming, that are not LGBTQ plus affirming, that will still try to do sexual orientation conversion. And these practices, though in many places illegal, are still happening in a lot of areas, which can lead to increased suicidality, increased substance use, et cetera. We also know that family rejection, being unhoused, struggling to find employment can lead people to engage in what we call street-based economies, which means you have to do what you have to do to be able to survive in a lot of cases. So in many instances, this may lead to selling drugs, engaging in sex work, which increases your risk of criminal legal involvement in police violence. What we also know is that LGBTQ plus people are nearly 4 times as likely as straight people to be victims of violent crimes. You know, when you think about this, there's a lot that goes into this statistic, but it's often, you know, I think with my own lived experience, what I know is that if I step outside, I live in a city, and what I know is that 20 minutes outside of the city, the landscape and my safety changes very, very dramatically. And so the way that I behave and that I act, and whether or not my wife and I even acknowledge that we are married, changes very, very much depending on the geographic location that we are in, because we know that we are at risk of very literal violence as we get outside of our spaces that we know that are more likely to be safe for us. For transgender victims of domestic violence, especially for transgender people of color, or those acting in self-defense, police involvement can often result in their own arrest. We also know that LGBTQ plus people receive higher bail amounts than others, often because there is a stigmatized perception that often leads people to be viewed as a higher flight risk or danger to the community. What we also know is that substance use, mental health issues, and things like that are much more prevalent in the LGBTQ plus community. And we'll talk a little bit more about that here in a few minutes. Next slide, please. So we've talked a lot about the trauma that the LGBTQ plus population experiences just in the world in general. And unfortunately, what we know is that trauma while incarcerated sometimes is even worse than what is happening on the outside. What we see is that the LGBT population are sexually victimized at much higher rates than straight people while they are incarcerated. And so this particular slide does not include the transgender population. This is simply the lesbian, gay, bisexual community. And so what we know is that about 1% of people in prison that identify as being straight are sexually victimized by staff, and that number increases 5-fold for those that are of a non-heterosexual orientation. We also know that about 2% of people are sexually assaulted in prison if they are straight, and that number increases to more than 12% if you are not heterosexual in prison. Next slide, please. Next slide, please. Thank you. Trauma for transgender people who are incarcerated is also incredibly concerning. We know that transgender people are 10 times as likely to be sexually assaulted by their fellow inmates than cisgender individuals. We know that they are 5 times more likely to be assaulted by staff. We know that transgender women who are housed with men are 13 times more likely to be sexually assaulted than cisgender male prisoners in the same facilities. And that 59% of transgender women report experiencing sexual assault in prison compared to 4% of the cisgender random sample. And then with this graphic over to the right, what we know is that the BIPOC, and so that stands for Black, Indigenous, people of color, transgender individuals, have especially high lifetime rates of incarceration. And so it's really important to understand kind of this intersectionality that's happening here. So if you are a non-white racial minority and you are transgender, the likelihood that you've experienced specifically sexual violence is astronomically more high than if you are of majority identities. And so, you know, I'm sharing this information to be really, really thoughtful about, you know, this is not simply to shock people, but it's to help people understand what is really happening. And often, you know, in terms of our clinical practice, so I'm a licensed mental health and licensed addictions counselor. And what I know is that often people know that in an intake assessment, if they disclose their sexual trauma, then probably I'm going to try to get them to talk about it. And often people don't want to talk about it. Right? That often what we know for the LGBT community is that physical and sexual assault is just part of our story. And it's happened often enough that we haven't even been able to fully understand or wrap our minds around the potential impact that it's had on our mental health, on our substance use, on our family systems, on our engagement with the justice system. And so oftentimes these sorts of things may be underreported. And so just bring us back to that slide where I mentioned the importance of assuming trauma. This is why that assuming trauma is really, really what we need to be doing.
Rachel, can I just add something to this slide? Because of these statistics, another thing that can happen is even if you are being made safe while you're in jail. So you the way to do that is often by housing people alone and possibly by housing people in administrative segregation. So the reason to know that is that the question is not just, have you been sexually assaulted while you were in jail, but also how are you housed? How are you treated? Because that in itself, being housed alone 23 hours a day when other incarcerated people are able to interact with others on their housing unit also is traumatizing.
Yes, thank you so much. And on the next slide, we'll talk about this a little bit more, because it is, Carol, exactly as you said. Imagine the space of having experienced such terrible violence on a repeated manner, and then often experiencing extended levels of isolation as what happens. And so what we know is that often in incarceration settings, jails and prisons have not put forth some of the effort needed to know, how do we keep these populations safe? And so often what will happen is, if there's an individual that has been assaulted, experienced sexual violence, to keep this person safe, they will be put what this says is indefinite prolonged solitary confinement for their own protection. And this happens across the globe, and it definitely happens in the United States on a regular basis. And so being put in segregation, protective custody, isolation usually means being locked down, which means being in your cell for between 22 and 24 hours a day with very little human interaction or activity. Research demonstrates that the clinical impacts of isolation on youth and adults include sleep problems that can result in self-mutilation, lower levels of brain function. That's for children. And youth. Adults can have similar issues and has a presentation actually similar to that of physical torture, which can include perceptual distortions, hallucinations, anxiety, rage, fear, trouble with impulse control, depression. This study, I made the slide and I'm getting goosebumps rereading it, is that a study of 1,200 respondents, and so this is not a small sample size, found that 85% of the LGBTQ population had been in solitary confinement versus just 20% of the general population. We know that many trans people who are incarcerated, like we said, have been placed in, and I just want to hit this one more time, indefinite prolonged solitary confinement, conditions that are classified as torture. And that this kind of isolation limits access to programs, rehabilitation, services, and increases risk of harassment and abuse by staff. And so what we also know is that for those, and we a few slides back saw the likelihood of assault by staff. What we know is that this happens more often than not in these sorts of isolation settings. And so there's a lot to unpack here on this slide. And in terms of working with this population, today we can't get into really solving this, but we want to at least draw a baseline understanding to the experiences of some of this population. Next slide, please. So another thing to think about as we're talking about what's going on with transgender people who are incarcerated, despite it being forbidden by PREA, many agencies house transgender prisoners according to their gender assigned at birth, which we have already covered, puts them at significant risk. We've also seen this be the case in residential SUD settings, in group homes, and those sorts of things. And so you can extrapolate this being assigned to a program based on your gender assigned at birth, if a person identifies as a different gender, as being a factor that increases significant risk for both mental and physical safety for the individual. Another factor, another trauma-inducing factor is searches in showers. We know that folks that are transgender are often strip searched to identify their genital characteristics. If there's somebody that comes in that is suspected of being transgender, they will be gratuitously strip searched in order to sometimes identify, mock their genital characteristics. They're also often forced to shower with genders that are incongruent with their gender identity. That increases their risk of sexual assault as well. We know, and this is a whole other presentation, is that gender affirming care is life-saving for individuals that are transgender. Often, depending on the state, sometimes depending on the county, this care can be defined and denied as being cosmetic. And so individuals that have been participating in gender affirming medical care for years will all of a sudden be denied due to the categorization of the institution that they're involved with. We also know that reporting assault and harassment for the LGBTQ+ population in carceral settings is often not safe, because it is often dismissed, is often retaliated against, or it will result in placement in solitary. And having worked in carceral settings with this population, anecdotally, what I've heard many times is, I would rather be assaulted over and over again than spend one more second in isolation. And when you're thinking about those two being your choices, that's pretty horrific. Next slide, please. So talking about the LGBTQIA population and substance use disorder, what we know is that we are at much higher likelihood of engaging in substance use disorder, 200% more likely to use smoking tobacco, 25% more likely to use alcohol, MSM stands for men who have sex with men. And so that is often an acronym that is used for individuals that may not identify as being gay or as being part of the LGBTQIA community, but they are men who do have sexual encounters with other men, are 12% more likely to use amphetamines, almost 10% more likely to use heroin, more likely to have co-occurring mental health issues, and a higher suicide risk. And what's important to know about this is I think there's a lot of misinformation out there that says the LGBT population is more likely to have depression, have anxiety, use substances because there's somehow something inherently wrong with us. And what the research shows, and anecdotally what people with lived experience know to be true, is that the trauma that we experience and the rejection that we experience day to day, substances will impact anxiety and depression, and that substances, at least initially, help the anxiety and depression feel a little bit better. For those of us that maybe don't know, one of the first ever prescribed antidepressants was chemically very, very similar to what we know today as street methamphetamine. Because guess what? Methamphetamine really helps with depression until it starts destroying the other aspects of your life, right? So what we know is that the LGBTQIA population is at higher risk for SUD and for mental health issues, but it is almost always due to the self-medication of the multiple traumas that we have experienced. Next slide, please. People who are now or have been in carceral settings are high risk of injury and death as a result of trauma, violence, overdose, and suicide, rather than people who have never been incarcerated. Overdose deaths are more than 100 times more likely for justice-involved individuals 2 weeks post-release than the general population. So that first couple of weeks after you get out of whatever facility that you're in, that is our most acute space for high mortality overdose. Post-incarceration syndrome is a term that is used for a subtype of post-traumatic stress disorder due to the trauma that happens when a person is incarcerated. Any of us that have spent any time in a carceral setting have heard the alarms and the alerts and the security procedures and seen the raids and the fights and the attacks and all of these sorts of things. If you did not have trauma prior to being incarcerated, after being incarcerated, you certainly have experienced traumatic events that will most likely result in PTSD symptoms. And so it's really important to know that just being incarcerated alone increases all of these risks on this slide. And then if you confound that with the trauma and the risk associated with being part of the LGBTQ plus population, that risk is even more acute. And research is really now starting to catch up to being able to define this kind of cross sector of individuals. Next slide, please. So when we talk about the LGBTQ plus population and SUD, the other thing that's really important to make sure that we keep in mind is the idea of minority stress. So this is a term that kind of describes the negative effects associated with adverse social conditions experienced by individuals of marginalized social groups, triggered by general social prejudice, which is defined below, due to just simply being who you are, as well as ever-changing laws and policies that can perpetuate acts of violence or discrimination. In treatment settings, social prejudice plays out like by using non-affirming language or practices, asking really intrusive or inappropriate questions that aren't relevant to care. One example of this that happens a lot is a person who's transgender will come to treatment for their SUD. And this happens actually quite frequently. In the intake, they'll be asked about their genital anatomy, which is not at all relevant to the care that they're receiving for their substance use disorder, and usually is just a product of the morbid curiosity of the interviewer, which signals to that individual, I am not safe here. Another thing that happens is refusing to honor a person's pronouns or acknowledge their family structure. My own wife has had the experience of a therapist saying to her, so what does your wife, or I guess if that's what you want to call her, have to say about this. So this happens in every, every sort of treatment setting that you could imagine. Again, risk of violence, employment discrimination, family violence, violent rhetoric against the LGBTQIA population. So we're seeing right now a sweeping trend of referring to the LGBTQIA population as people who are groomers or pedophiles. And anybody that has heard that, there's some resources linked on this slide, and I would really encourage you to take some time to do some research into that, because what we know is that most people that have been convicted of sexually abusing children are actually heterosexual. And so some of these really problematic narratives really play into the increase in violence and discrimination that our population is experiencing historically, as well as a recent really significant resurgence. Next slide, please. So what can we do about this? It is really critical that you educate yourself on the trends of needs of the LGBTQ plus population, especially for those who have been incarcerated, which is a lot of us. And that you understand that where and how discrimination in terms of employment and housing really may be a factor in some of the things that you're navigating in terms of helping get your clients on their feet. Anything you can do to display visible signs that you're part of the community and or an ally is really, really helpful. I will tell you, every establishment that I go into, I am looking for some sort of a symbol that I am safe there. And if you can do that in your treatment setting, a picture goes 1,000 miles in terms of demonstrating the safety for the people that you're serving. Encourage mental health supports. For many people that have had repeated acute trauma, the trauma becomes such a norm in our life, in our narrative, in our life story, that we don't even really have an awareness of how it's impacted our development, our behavior, our existence in the world. And so sometimes being able to educate and gently name those things and to say, you're not crazy, you are not the problem, you have experienced trauma, and that has affected your behaviors and your ability to function in the world. And guess what? You can feel better is hugely, hugely important. And also encouraging and naming the importance of mental health and SUD treatment. Again, for many of us, the anxiety and depression that we have felt due to minority stress, especially again, keeping in mind those intersections of other sorts of identity are really common, and we kind of get used to it sometimes and forget to understand, gosh, this might, maybe I don't have to live with all of these active symptoms surging all the time. Hold yourself and team members accountable for stigmatizing and or non-affirming language and practices. Pre-screen your resources to make sure that you're not sending your LGBTQ plus people to agencies that are going to not be affirming and or have problematic practices in terms of trying to change people's sexual orientation, not validating their family structure, et cetera. And making sure that the living settings that you have connections with are trans affirming and that already have practices, policies, and procedures in place to be safe, affirming, and not segregating for individuals who are transgender. And to work with patients on the connection between things like trauma, physical health, and substance misuse, and to help people understand that all of these things come into play in terms of how we are presenting and interacting with the world around us. For people that have been in and out of carceral settings and have had to live on the streets and have had to participate in street economies for survival, they may not be familiar with terms like minority stress or social injustice or social discrimination, and they may not understand consciously how that has impacted their development. And this is a real opportunity to help people draw some connections between their experience and their symptoms, and then consequently draw a direct arrow to a pathway toward potential healing. Next slide, please. So as we're thinking about all of the things we talked about, and I know that section was heavy and a lot to unpack, and there was a lot going on in there, I want you to think about Mark. And so Mark is a man who identifies as gay, who has opioid use disorder. He wants to maintain sobriety, but he's had bad experience with therapists, 12-step groups condemning his sexual orientation. He's experienced numerous instances of harassment and assault while incarcerated, and he needs some help getting connected with work and housing. And we know, as we mentioned, that that first couple of weeks after getting out of incarceration are really, really high risk, especially for those with opioid use disorder. In the chat, would you mind sharing, and take a moment, what would be your first step in starting to work with Mark to help his reentry journey be successful? So Mark, and I'll just kind of repeat his characteristics as you all are thinking and entering your thoughts into the chat. Identifies as gay, cisgender male, has opioid use disorder, wants to maintain sobriety, but has had a lot of trouble experiencing support in that area due to therapists and 12-step groups not being affirming of his sexual orientation, has a lot of physical and sexual trauma while incarcerated, and is hoping to be able to gain employment and housing. So as you all are typing, I'm going to go ahead and kick it over to Carol.
Okay, thanks, Rachel.
Thank you, Carol.
So can we go to the next slide, please? So for the time that's left, we are going to be talking about another group that's a special population, and that is people who are pregnant and have substance use disorder within the criminal justice system. Next slide, please. And I just want to say what we'll do is we will leave some time at the end to, I see that there has been somebody who has talked about, has answered Rachel's question. And so we can go back to that at the end if that works out. Okay. So the first thing that we want to look at, and I know I often throw these numbers up here, and really what I want people to walk away with is that there are many infants that are exposed to alcohol and other substances during pregnancy. Every year, more than 400,000. And also that the number of pregnant people with OUD increased a lot from 1.5 to 8.2 per 1,000 live births between 1999 and 2017. So again, in almost any group that you look at, right, the incidence of opioid use disorder, and that's OUD, has increased, and that is true also for people who are pregnant. And then when we look at, are these people, pregnant people, able to get treatment as easily as the rest of us are? And actually in one study, what they found is no. And the reason is if somebody is pregnant and you are a treatment provider, there are more issues that you would have to think about, right? Prenatal care and are they going to give birth while they're in treatment? And so there are more treatment facilities who are going to say, no, we're not able to take pregnant people. So they're less likely to get treatment, which of course means that they are more likely to continue misusing substances and therefore more likely to end up with justice involvement, either in jail or on probation. Next slide, please. Now, I will say, and many of you might have heard this or learned this, that in many jail settings, in many counties, the jail staff will do what they can to have people put more on diversion and not be in jail while they are pregnant. However, that's not always possible. I worked in a correctional setting for many years, in a county jail for many years before coming to HMA. And there were many times where there'd be a lot of advocating for people who were pregnant to be able to get out of jail and, placed on probation, released on their own recognizance, and it would always be up to a judge. And so there are many people that will be in jail who are pregnant. 6 to 10% of incarcerated people are pregnant on any given day, which is a pretty high number. 1,400 people per year will give birth while they're in custody. Now, what does that mean in terms of healthcare? So jails and prisons have to provide healthcare, right? They have to provide withdrawal management services. They have to provide basic healthcare. They have to provide basic mental health care, which means that people have to be evaluated at some point while they're in custody. The National Commission on Correctional Healthcare is the organization that within the correctional healthcare community, we look to the NCCHC as the organization that is going to develop standards and best practices for people who are in jail. So the NCCHC does have standards for pregnant incarcerated people around parental health, prenatal care, referring to specialists. However, many jails and prisons really don't have very good written policies on the care of pregnant people. So even though this number, 6 to 10% of incarcerated people are pregnant, very often that group is overlooked when we're looking at, let's put together some policies on treating special populations where there is not a focus on people who are pregnant. And so therefore, there's not a lot of guidance for the medical staff, mental health staff, and SUD staff for working with this population in carceral settings. Next slide, please. And what does this mean for the baby? So babies who are born during incarceration are more likely to be born preterm, small for gestational age. And you can just imagine why that would be. We have a few things written here, but more likely the mom was misusing substances. More likely there are chronic medical conditions because many people who end up in jail are living below the poverty line and therefore not getting proper prenatal care, higher levels of stress, more tendency towards violence, poor nutrition. And again, as I said, there might be limited access to reproductive care. So you put all of those together, and I'm sure that you can think of other reasons that this might be true. You end up having a parent who is at risk for many things. Remember that many people who are incarcerated are suffering from co-occurring disorders. So you have a mom who is already under stress, or a parent who's already under stress, and then they're more likely to have a child who from the beginning has some special needs. Next slide, please. So what are the opportunities to support pregnant people within the criminal justice system? So when we move to there being an opportunity to for ECM providers to have to do in-reach services, so they're able to go into the jail prior to release of the person and start working with them. What are some ways that you can support people? So the first thing that we see here is a continuation of the pregnancy. So really finding out if the pregnant person, what is their plan for the pregnancy? And based on that, what are the appropriate referrals? That can be difficult for some people to think about asking that question, but it is important to have a MI approach. I know probably anybody who has been pregnant before knows that you get lots of advice from a lot of people on what is the right way, right, to give birth, to take care of your child, and so on and so forth. And so that is really important, to take that motivational interviewing approach and really working with the pregnant person on what is it that they need, what are their plans for the pregnancy. What are their risk factors? Is there a substance use disorder? Is there a co-occurring disorder? Is there a mental health disorder? And what effect does that have on the pregnancy in terms of things like services, medication is an important question to make sure that they are getting the correct follow-up care. Also making sure that they have access to all of the health care that they need. And I am going to add to that, and we'll talk a little bit about this in future slides, is making sure that as an ECM provider, you're finding out what services they're already getting. If they're in jail and they gave birth while they were in jail. They might already have CPS involvement. They might already have probation involvement. They might already be working with a medical provider if they have special needs. So it's important to look at all of the services that they need and what services they are already getting and what are their future needs. Next slide, please. So we want to talk a little bit about the influence of race and ethnicity. So when we're talking about the BIPOC population or the Black, Indigenous, people of color population, they're at highest risk for poor pregnancy and poor birth outcomes. They also are more likely to be incarcerated just in general. And so when we're working with this population, it is really important to look at what are the needs of the parent and what services has already been provided to them. What are some of the reasons that they are more likely in general to be incarcerated? Well, there are, and this, as Rachel said, this is a long discussion that we can have, but basically what you want to look at is this structural racism, that is a root cause of some of the inequitable birth outcomes, right? So there might be parental stress. There might also be less access to quality healthcare prior to the birth, residential redlining. So there's a lot of stressors that just are going to go along with being a member of the BIPOC population that is going to affect pregnancy, even if a person is not justice involved, and then even more if they are justice involved. Next slide, please. I know that there has been a lot of training on trauma-informed care, but I do think that it's important to talk about this specifically when you are talking about working with incarcerated pregnant people. There are many aspects of incarceration that are stigmatizing, that are traumatic, but specifically for pregnant people, what are some of the things that a pregnant person might really suffer? So the first one that we have listed is that stigma and negative judgment. Now, as an incarcerated person, there is already a big chance that there is going to be stigma and negative judgment, right? There's always going to be custody staff, medical staff, mental health staff who feel like, hey, you did something wrong and that's why you're here, don't have high expectations. But when you are pregnant, that is even going to go one step further because there can be judgment around, gee, you did not take care of this life that is growing inside you, and people can have very strong feelings about that. So that tendency toward that stigma and negative judgment, again, is going to be one step further for somebody who is pregnant. There's a lack of privacy in terms of your living environment, but also even medical care. I mean, in many jails, there's always going to be a door open and a custody officer who's standing nearby when there's any medical procedure being done. So there is a lack of privacy. There's a lack of choice on healthcare provider, right? Generally, when you're in jail, you are treated by whoever is there. And again, imagine if you had any health condition that was going to cause you stress and having to have somebody provide treatment where you don't feel like they are really going to understand your needs. But when you're in jail, there are no other options. There's no going back to your health plan and saying, hey, I want to speak to somebody else. You're just stuck with that. And then the other trauma, of course, is if you give birth while you're in jail, you're always going to lose that newborn. Hopefully, the newborn will be going to a situation that you have some trust in, but not always. And again, there is no choice. There's no way to keep a baby while you're incarcerated. Next slide, please. in addition, it's important to just say something here about restraints, because this is something that there has been a lot of research on and is outlawed in 2012. So what this means is if somebody is giving birth, they're not going to give birth in the jail, they're going to give birth in a hospital. And very often when somebody is an incarcerated person goes to a hospital, they'll be shackled so that they can't escape. They don't have somebody waiting outside who's going to help them to escape. That is really dangerous, as you can imagine, for somebody who is pregnant. If your legs are shackled and you're you trip and fall, I mean, obviously all of that can really hurt the baby. And so that was outlawed. However, in one study you can see in 2018, most nurses reported that pregnant people are regularly shackled. Now, why would that happen? We know that when anybody is in custody, safety is paramount. Safety comes first. And so it is pretty easy to be able to say, yes, I understand that this is the rule. However, there's a safety issue. We are really concerned about this person being able to escape, or we're really concerned about this person's risk for violence. And so therefore, we can have a special exception where we shackle this person. But what we find is that is not, that's more the rule than the exception, that pregnant people are restrained while they're in jail. And, there's, again, the potential trip and fall. It can interfere with appropriate medical care. So if you are giving birth, you might not be able to move as well if you're shackled. And so it can just cause a lot more pain, a lot more complications. And so that's just a specific trauma that's important to be aware of for pregnant people. Next slide, please. So what are the re-entry considerations for pregnant and postpartum people? So one thing, again, that's important to remember is, as an ECM provider, you are looking at coordinating services. And if you are working with a pregnant person who is re-entering the community, who is being released from custody, there could already be many different departments that are involved with this person. There also could be none, but there could be many, especially, again, depending on when they gave birth, what their condition was there a referral to CPS? That doesn't automatically happen if somebody, in California, if a baby is born and has signs of substance exposure, they don't automatically have to be referred to CPS, but they're more likely to, depending on their situation. And so it's important to look at who is already involved with this parent, and then what was their experience while they were incarcerated. Remember to look for what was the trauma that they experienced, if any, while they were incarcerated, and it's likely that they did experience just some of the things that we talked about, but to find out about what was the medical care that they received while they were in jail. Were they stigmatized? What was their experience of that? And then again, what are the treatment linkages? What does this parent need when they come out of jail? The prenatal care that's in jails can vary from jail to jail. And so they might have had really good care while they were in jail. There's going to be a need for that continuity of care, though. So that's just important to find out about, even if you feel like, hey, I've worked with my jail, I know that they provide good medical care there. But still, that continuum of care is going to be very important. Next slide, please. Here are some of the questions that have to be answered. What's needed to allow parents and their babies to stay together? What is it that the parent is wanting to happen? Maybe the parent will be feeling like, I have a family member that I would like to be taking care of the baby while I get my feet on the ground. And again, it's important to really keep our own judgment in check about what the needs of the parent are when they get out of jail. And then, what are the immediate needs? Do they need housing? Do they need food? What services have they been provided? Where are providers located? There's many, and I know there were, when we talked about the counties, there's many people here who are working in rural counties. And so where are the providers located? Is there a way for this parent to easily be able to get to services? SUD care, so substance use disorder care, and also I would add to that mental health care. Is this parent on any medication, either for SUD or for mental health reasons? What are the interventions, psychosocial interventions they were already being provided? And what are the needs for them to be provided? Is there childcare available? As we talked about, is there a way for this parent to get to treatment? And what is their home environment like? Are they a home environment that's going to be supportive of their recovery? Next slide, please. So we're not going to talk very much about plans of safe care because we don't have enough time to do that. But in a plan of safe care, that's that POSC, that would be a plan that is developed for the parent that is going to support safety for the mother and safety and care for the mother or the father and the child when they are in the community. And so again, it's important to look at what are going to be the needs of this family. And is there already a plan there? So has there been a plan of safe care that has already been developed? And if there has, who is working with this person? What are the additional needs? And really looking at all of those phases from prenatal care, what is the support that's needed through that postpartum period. Next slide, please. Okay, so this is just a little more information about the plans of safe care that traditionally plans would be completed by different disciplines. Now, as many of you know, when plans are completed by different disciplines, they could have either, different focus, there could be an overlapping focus, there could be a question about who is providing what services. There's a discharge plan that's could be looking at the health and well-being of the infant, a child welfare safety plan, looking at the safety of the child, SUD and mental health treatment plans. We're looking at the treatment needs of the parent. And in a plan of safe care, all of that should be coordinated, that it's more comprehensive and it's interdisciplinary so that you don't have that kind of overlap of services. Whenever you have an overlap of services, there's always a risk that there's going to be a gap in services, right? That there's an expectation that somebody else is taking care of that. So in a plan of safe care, you want to look at safety issues. You want to look at treatment factors and what are the treatment needs. And then you want to look at what are the health and development needs of the infant. Next slide, please. These are just some of the domains that might be in a plan of safe care, assessment and referral. And generally it would not be up to the ECM provider to put together a plan of safe care. That would be put together through child welfare. And again, you would be looking at medical care, at treatment for mental health, substance use, looking at what are the supports, parenting supports, What are the needs of the infant in terms of health, safety, and their development? Next slide, please. Okay, so what we would like to do now in the time that we have left is we're going to look at these two scenarios, and I was seeing that there were some questions. So I think what we'll do is we'll start quickly with the scenarios. If you could go to the next slide, and what we are going to do is I'll just read the scenario, and then if you can answer in chat to the questions. And basically we want to be looking at how would you support this person if they were justice involved, if they were just coming out of jail. So the first one, Sylvia is a 43-year-old transgender woman. She has opioid use disorder. She has significant depression and anxiety. She's currently housed at a men's reentry facility with release to the community in the next 90 days and is seeking employment and housing. So what would be your first steps in supporting her?
And Carol, while people are typing their answer, I would, if it's okay, I'll go ahead and answer one of the questions that was in the chat. Sure. So we had a question that said, how do we identify a gender affirming care provider? How to manage care plans, identify these providers and networks. And I'll bet we need to work on expanding these networks and providers for access. And just to respond to that generally, in my own practice, typically state by state, there will be websites that list providers that are known to be either gender affirming or LGBT friendly or affirming. And then oftentimes I've had to do my own legwork to make sure and to create my own list. And while I wish that wasn't the answer, often it can be. And if there's a resource that somebody else knows about, please jump in and fill in the blanks. But in my own practice, what I've had to do is truly get on the phone and say, and ask some questions about what's your approach to working with people who are transgender? What's your approach to working with people that are LGBT? If it is, as an example, a housing provider, do you provide equitable treatment to same-sex couples that have children? How does that, how do you work? And I've had to really kind of do some of my own legwork around that. And then I would share that with the people in my community as well. And I know this answer is going to be a little vague, but I think it's also honest that different managed care entities kind of all have different approaches to this. And I think there is a need nationally really to work on centralizing the knowledge and understanding of providers that are affirming. I think to access federal funding, in theory, people are not supposed to be discriminatory around sexual orientation, gender identity, et cetera. But that doesn't always mean in practice that that's where the rubber meets the road. And I think, Carol, you already answered the question about the plan of safe care typically being done by child welfare rather than the ECM team. Okay. All right, I'll kick it back over to you to talk about some of the things.
I'm sorry, I was on mute. The ECM provider, if I am not talking, I'm probably just on mute. The important thing for the ECM provider is to find out, is there a plan of safe care already in place? And if there is, are all of the services being provided? So it would be more in a supportive role for the plan of safe care. And then let's see, I would like to look at some of the responses to this first scenario. What would be your first steps in supporting her? And I see finding housing, connecting her to job training and support group, housing assistance, housing. Let's see, identify and vet resources before referring her. Conducting an assessment to help identify the patient's strengths, challenges, and goals. And all of that sounds great. I don't know if there's anything you wanted to add to that, Rachel, before we.
Yeah, I was just going to say, I appreciate the all caps vet resources. I think that is huge. And I think especially given, you know, in this, the third column here that talks about her being housed at a men's reentry facility, there's a lot to unpack about what's probably been her experience in that space. And so in order for you to maintain rapport and really be able to make progress with this individual, vetting, you know, even just saying, hey, I want you to know that I have vetted these places for you, and here's the evidence that I have that is supporting my belief that this will be an affirming place for you, is really, really a wonderful place to start. LGBT outreach programs in our area for housing and SUD. I see validate her identity, name, and pronouns first and foremost, build rapport, help her feel supported and safe. I appreciate all of these answers are phenomenal. And so I want to say I appreciate them all. But, you know, as I talked about in one section of my section, we, you know, all of those signals to say that you are safe, especially what we can assume is that Sylvia has been through a lot in recent weeks, months, and years. And so taking that extra initiative to be validating, to signal, I support you. You don't always have, you don't have to get the name, you don't have to get the language right. We all, many of us, I guess maybe not all of us, many of us make mistakes sometimes with pronouns or names. And really what is important is that we correct ourselves, apologize, and move on, right? You don't have to be perfect to be an ally. You can do your best, and your best is often trying to be validating and running the traps and doing some legwork on this client's behalf to make sure that you know that she's safe. So thank you.
And Christina just said at the end, we don't want to add to the list of traumatic experiences for her. And I think that is just really important to think about the way that we're working with somebody, and are we acting in a way that could be re-traumatizing, even if we don't mean to be re-traumatizing. So let's go to the next scenario. So Robin was incarcerated for 10 months and gave birth while in jail. Robin's mother took custody of the baby 24 hours after birth. So if that is the only information you have, what would be some additional information that you'd like in order to plan services? And what linkages are you going to consider? And as people are thinking, I just want to make sure that I go back and to make sure that there were no other questions. And I don't think that we missed any others.
I don't think so either, but I'll also scroll and make sure.
Okay, great. So one thing, and I will start to answer that question because we just have a few minutes, but please add in there. So one thing that I think would be really important is what additional information would you like is, again, as I said, what services is Robin already getting? You know, can you connect with the person who is providing those services and making sure that you're looking for the gaps? And so Robin may have many needs. And so making sure you know what's already being done so you can focus on what's not being done is really going to be very effective. Christina said, does she have a relationship with her mother? Absolutely. That would be an important thing. You know, it could be that, you know, Robin is really okay with that. But if there was not a relationship, what happens then? Has the mother brought the child for visits? Christina, that is a great question. So Robin's mom took the baby, and then what happened after that? Did the baby get to visit the mom? Another question would be, what happened while Robin was in custody? Was she allowed to, in some jails, you would be allowed to pump if you really if you felt like you wanted to chest feed, is that something that was able to happen for her? So that would be another question. And then let's see, does the mother plan to work toward custody after release? And again, yes, that is a really important question because I think it's an assumption. Okay, well, you gave birth, you're going to want to take your baby back, but maybe not. And that can be a very difficult thing for the parent of the child to be thinking about. So really to think about that, what I talked about before, the amount of stigma that's more than, just general population stigma, which always happens in a jail, but the amount of stigma that pregnant person probably went through while they were in jail. And the amount of judgment, it's just so important to really stay connected to what is it that Robin is wanting, what is it that Robin is needing, and to do a really comprehensive assessment of that, in addition to the baby, Robin's baby. How safe is Robin's baby? Where is Robin going? Is Robin's mother, is that an environment that is safe for the baby? Another question might be, what's the health of the baby like? Is the baby, remember that there's a higher likelihood that the baby will have been born preterm or small. And so what are the needs of the baby? Because we know that there's a higher likelihood that the baby is going to have some special needs, at least in the beginning of that baby's life. So I am not seeing any other questions that people have. And I mean, hopefully from the second part of it, hopefully the biggest thing that you got from it is to, when you are working with a person who is or was pregnant while they were in jail, to really think about that this person has likely been traumatized, to think about how different it would be to be pregnant while you're in jail, and to remember that everybody's needs are going to be different, and that a trauma-informed approach means that you are really listening to the client and what the client's needs are for services, and working with them to be able to get the services that the person needs. Rachel, I don't know if you have any parting words before we stop.
I just want to say thank you so much. The chat was wonderfully engaged. You all were a great audience. Again, we are here to help people we serve the best that we can. And I just encourage you all, if there were areas here that you had a moment to say, well, gosh, I wish I knew more about this, or this part felt confusing, or I'm not clear on this thing, please take that make that into a commitment to learn more, because we all are truly in this together, and the people that we serve need us. And so you all are so important, and I appreciate your engagement and your participation today.
Great, thanks. And we're just going to pass this over to Mary Ellen.
Thanks everyone for your participation today. As an FYI, once the webinar concludes, there will be a separate survey that will pop up in a separate browser for you. We would love to hear your feedback for today, and definitely improve on future training opportunities. Again, reiterating that the recording link and slide deck will go out to all participants for today as well. Thank you so much again.
Thank you.
Have a great rest of your week.